Good afternoon. I'm Edmund Bonikowski, a consultant in Rehabilitation Medicine, also founder and medical director of NRC Medical Experts. And I'm joined today by my colleagues Michelle Kudhail and Rob Poppleton. Michelle is a neurological physiotherapist. Rob is a consultant clinical neuropsychologist. And between the three of us, we're going to give you a run through of functional neurological disorder, tailored for medico-legal teams. Okay. Next slide, please, Michelle. Thank you. Oh, here we go. So the aims of the session today are to provide an overview and an update of current research and best practice, explain the biopsychosocial model, which many of you, of course, will be aware of, but I think it's useful to go through it again, and to highlight the challenges associated with the litigation process, and I'll do that right at the end. So quickly, the epidemiology. Functional disorders are the second commonest reason to see a neurologist after headache. As we know, neurologists specialize particularly in headache and epilepsy and so forth. They do not specialize in acquired brain injury and spinal cord injury, and that's a subject of another presentation we give. And so they see a lot of functional disorder. And it accounts for about 5 to 10% of new neurological consultations. That's a heavy burden. The incidence, conservatively, is about 12 per 100,000 per year. So that's new cases coming along. It's rare in children under 10 and those over 80. And importantly, comorbid neurological conditions occur in about 20% of cases. So that's more than would be expected by chance, but that's important because one of the sort of central tenets of the presentation is that you can have functional neurological disorder as well as a neurological disorder which is grounded in some physical pathology. So there we are. There's the epidemiology just in graph form. 50 to 100,000 people in our community in the UK have this condition. That's the prevalence. About 8,000 newly diagnosed. Well, that's different from the 12,000 it said on the previous slide, but it's these are approximate numbers. And women are disproportionately affected more than men, and a ratio of around about 3 to 1. In a large, this is interesting, in a large cohort study of 1,030 patients with functional disorder diagnoses from a neurology clinic, 1 in 4 patients had acquired a new neurological diagnosis that better explained their presentation after 18 months of follow-up. The implication being there that it's very rare to miss a neurological diagnosis in preference to making a diagnosis of functional neurological disorder. So here we have an interesting slide about myths. And there have been a lot of myths about functional disorder. So let's just run through a few of them. Even in recent years, it has been labeled as a diagnosis of exclusion. The idea that a neurologist would run through one after another condition, checking them and so forth. And then only when they reach the end of a long list were they able to say, well, it isn't any of these, therefore it's an FND. And actually, nowadays, a different approach is taken where functional neurological disorder, FND, is ruled in based on the presence of positive signs. There's a myth that patients have either FND or another neurological disorder, and from my previous comment in the previous slide, you'll see that they commonly co-occur. That a bizarre presentation indicates FND. Well, not necessarily. Different phenotypes of FND, and these are different sort of physical presentations, phenotypes of FND indicate different disorders. Well, functional symptoms are often part of a broader FND syndrome, including pain, fatigue, and cognitive symptoms. FND symptoms are voluntary. Well, symptoms are involuntary. Patients are not putting them on, and feigning is rare. No role for investigations in the diagnosis of FND is a myth. Well, investigations can be useful to identify comorbid neurological conditions and diagnose phenotypically what the functional neurological disorder is. Less harm in missing a diagnosis of FND than missing another neurological disease. Well, FND is not misdiagnosed more than other conditions. Erroneously diagnosing FND as another neurological condition can be as harmful as the reverse. And another myth is that FND is exclusively a psychological problem caused by psychological factors. Well, we now know that that is not true. Psychological factors are one of many possible risk factors for FND and should not be considered the sole etiological cause. Prognosis is usually good. Well, no, I'm afraid that is not so. And the treatment of FND is solely referral to a psychologist or a psychiatrist. Actually, FND treatment is individualized and involves careful explanation and combinations of physical and psychological rehabilitation. So there's been a great shift from the myths to newer research-based ideas, and I'm probably just going to mention a little bit about that in a moment. Next slide, please. Oftentimes there is a preceding event. We're all familiar with the idea of predisposing factors, precipitating factors, and perpetuating factors. So these are precipitating factors. Over 80% of FND patients report a preceding event that is, in this particular study of 40 patients, it was injury, infection, neurological, and so on. You can all read that. And 38% of people report having a panic attack with the event. Comorbidities, these are other conditions that go along with somebody who has a positive diagnosis of FND. Depression is extremely common, general anxiety disorder, PTSD, panic attacks, as I've said in the previous slide, OCD, and the quality of life issues which affect people are predominantly pain, fatigue, poor sleep, poor concentration, and bladder and bowel dysfunction. So just because the perception out in the community is one that of, this is not a real diagnosis, these are not real conditions. I just wanted to highlight a couple of things in the literature. So FND is a common condition describing a spectrum of neurological symptoms such as weakness, sensory changes, seizure, gait disturbance, tremor, and speech disturbance. Pardon the slightly peculiar gaps and so forth here. Several terms have been used to describe it, though some of which, including conversion disorder, dissociative disorder, etc., are no longer really used. The current DSM-5 manual now calls it Functional Neurological Symptom Disorder (conversion disorder), which is a change from the simply conversion disorder in the DSM-4. So you can see the understanding of this and the presentation of it in the medical community is maturing. And now DSM-5 defines FND as one or more symptoms that affect body movement or senses. Findings on examination provide evidence of incompatibility between the symptoms and other recognized neurological disease. And symptoms cause significant distress or problems in social functioning, work, or other areas. It's a very good all-encompassing definition there, which I think is useful to refer back to in all of our thinking. Next slide, please. And just to sort of emphasize that this is not a purely psychological problem, potentially. More recent pathophysiological explanations of the mechanism of FND allow for the importance of psychological factors, yes, and experiences, but also examine FND at a neural level, and they include aberrations of predictive coding framework, overactivity of the limbic system, and dysfunction of brain networks. So what we're seeing here is the scientists looking for chemical rationale for FND. In a predictive processing paradigm, prior beliefs and experiences form predictive models about the world, which are continually modulated by top-down beliefs and bottom-up sensory information. In FND, it's hypothesized that abnormal predictions about movement, impacted by abnormal directed attention, overwhelm sensory evidence, resulting in the generation of movements that occur without a normal sense of volitional control or agency. So some really hard science in here. So these conceptual models may be supported further by functional and structural changes in the brains of people with FND, which have demonstrated evidence of increased connectivity between motor control, and emotional processing areas, as well as alterations in networks related to a sense of agency. So what I really want to emphasize here is there's some hard science backing up the concept of FND. So I think now that's my introductory slides. Hand over now to Michelle, who's going to talk us through the biopsychosocial model. Michelle.
I can come off mute. So the biopsychosocial model of illness, which identifies the biological, the psychological and the social factors that are associated with illness. When thinking about the predisposing factors, particularly with people with FND, there was kind of a belief that everybody with FND had some kind of stress or were depressed or anxious. Now, whilst people with FND are 2 to 4 times more likely to have had adverse experiences either in childhood or in their adulthood, for example, physical, emotional or sexual abuse, it's not the case with every single individual that presents with FND. The precipitating or triggering factors are events that might initiate the symptoms of FND. And the perpetuating factors are those that will reinforce the ongoing symptoms of FND. So thinking about I can move on to the next slide. The precipitating factors. So this will often occur in close temporal proximity with the onset of symptoms. So between 50 and 80% of individuals have some kind of trigger or report some kind of trigger. When thinking about some of the biological triggers, this might be a physical injury or an accident that has occurred. From a social perspective, this might be social stress, high expectations, and there's been a rise in young people, particularly within the sports field, who have these high expectations who then go on to develop FND symptoms. And from a psychological perspective, this might be a particular increase in stress or a panic attack. And I particularly remember a patient who was just going off to university, he was in a new environment, high family expectations to do well at university, and he really wasn't enjoying his course. It was also, he was gay and he hadn't come out to his parents, and there was all this stress going on, and he presented with real physical disability where he was very dependent, he was hoist dependent, he couldn't speak, he couldn't swallow, no sitting balance. There was quite significant physical impairments. So people with FND who are able to report their triggers, 88% identify at least one trigger, 56% have combined triggers, there might be more than one. The functional movement disorder phenotype, so the characteristics that are observable that Ed has already mentioned are often weakness, gait disorders, tremor or jerks, Parkinsonism features. And patients will often report non-motor symptoms as well. So this might be fatigue, pain, headaches, dizziness, and panic attacks. Of those patients who had identified a trigger, 74% reported that their symptoms were paroxysmal, so a sudden onset, an increase in symptoms. And 26% identified those where there had persistent symptoms, but variability within the presentation of them. When thinking about the perpetuating factors, these are factors which will reinforce the FND symptoms. And from a physical conditioning, from a physical perspective, biological perspective, this might be in some cases where patients are unable to be, they're not mobilizing, or they're immobile for a prolonged period of time, that they will have physical deconditioning. So their physical fitness is reduced. They'll have muscle weakness because they're not performing motor tasks. And in some extreme cases, they might have physiological shortening of their muscles and developing contractures as a result of being in a position for a long period of time. From a social perspective, they might have ongoing psychosocial stress regarding work or their family situation. and from a psychological perspective, any untreated anxiety or their illness beliefs regarding a diagnosis or a potential lack of diagnosis, which can also be particularly stressful. This will be compounded by disability-related financial benefits and also the litigation process. And these factors will influence all stages of their symptoms. From a biological perspective, the presence of organic symptoms. We know that females are more likely to develop FND, and also their vulnerabilities of the nervous system. So if somebody is anxious and believe that they're unwell, and their immune system will be reduced, and therefore potentially have a greater potential for their illness. From a psychological perspective, they might have an emotional disorder or personality disorder associated, and also misperceptions of their diagnosis. And from a social perspective, they're likely to potentially going to have socio-economic deprivation. They might have had significant life events, as I mentioned previously. And then also the social benefits of having physical symptoms, including kind of sympathy, attention, financial benefits, and potentially housing as well. So I'm going to hand over to Rob now to run through the assessment of FND.
Okay, we'll look at the twin pillars to form FND diagnosis, and this is important in the medical legal field as well as the medical field, because you get an inconsistency of symptoms or disorders over time, which are influenced by internal factors, and incongruity. The disorder breaks the rules that you expect from normal diseases. I think an easy way to think about this is, in the past we talked about conversion disorder, where a person would say get paralysis of the right hand. Now, in the old days, the test used to be that used to lift the hand above their head and just let it go. Now, if it was a true paralysis, the hand would crash onto the head. If it was more function related, the hand would suddenly move away from the head so the person wouldn't slap itself. So again, it's an indication that something more than physical disabilities going on here. Next slide. Michelle, next slide. Thank you. Again, FND is very difficult to diagnose. In the past, we used a range of terms from conversion disorder to psychogenic disorder to socialization disorder, and even use the term hysteria. I think this shows that over time we have refined the definitions. We've become better at trying to detect it. And as we come on later, it is very, very important in the medical legal framework to be able to tie it down more constructively. It also has quite significant implications for future treatments and future approaches, because FND can be treated. It's usually better if it's picked up earlier because you have better prognosis. Unfortunately, if it happens over a sustained period, it's less likely to respond to treatment in the short term. Also, you need to look at, well, so DSM-4, sorry. Also, you need to look at other symptoms that can go hand in hand with, like I said, migraine, acute. The big ones at the moment are looking at fatigue and sleep, because clearly if you are fatigued or you have poor sleep pattern, treating that can be very beneficial in the long term, because people have more energy, they feel more energized to participate in treatments. Next slide. As Ed has already mentioned, that DSM-3 is the manual that medics use to try and define symptoms. This is the criteria from DSM-5. As you know, they are quite broad, the definitions, but again, it can be a very useful guide into making more accurate diagnosis and labeling of FND. Next slide. Okay. It's really important in these conditions that teasing the symptoms out and to see if they're consistent with neurological disorders. Classic examples are, I had a lady who claimed she had a stroke. And again, the stroke was left-sided part of the body. You expect them to have visual spatial deficits and other factors. But when, she had problems talking, but when you asked her to write things down, her speech was very fluent because she was left-handed, and there was no sign of left-sided damage, which is quite interesting. We now try and break them down into two broad terms, what we call factitious disorder, malingering. Malingering is very important in the medical legal work because if people aren't putting full effort into their assessments, you're less likely to get accurate results. And we'll come on to talk more about that in a minute. Factitious is more usually unconscious driven for other reasons. And it needs to be teased out because, again, if that is the cause, then obviously if you treat the cause, you're more likely to have better outcomes. It's also important to think about gains and incentives and what drives it. And unfortunately, in the medical legal world, and we'll come to it more, that people tend to exaggerate the symptoms or increase the symptoms to basically to be listened to more or to be taken more seriously. And in that case, we come on the bottom, you need to think about the incentives. And I think, unfortunately, we live in a culture that does incentivize disabilities. And the classic example of that is particularly benefits, that if you say you can walk 10 meters without difficulties, you get less benefits. If you say on a bad day you can't walk 10 meters, then it opens the doors to get more benefits. And therefore, money obviously is very important in life to live a good quality of life. So again, people do tend to have natural style to increase their disabilities with the view that hopefully they will get better compensated or more incentives to do that. Next slide. Trying to make this a bit clearer. I think, again, life is never this simple, that we tend to think about unconscious and intentional. I do think more and more patients I see with this condition, I think it's on a continuum that you get a percentage of each. But if you look at the top, if it's unconscious, there's no gain to it. The symptoms are more difficult to treat. At the bottom, you have two types of the intentional ones, where it's unconscious, internal primary factitious disorder. And I think a classic example, I was working with a case the other day where you had twin sisters, and that clearly one of them had quite marked FND symptoms, but it's very evident that she was trying to use her symptoms to get more attention from parents compared to her other sibling. On the bottom, obviously intentional, so it's more secondary gains such as compensation, time off work, etc. And the Americans tend to call this word malingering. In England, I think we tend to use a reduced amount of effort or lack of effort. So the next slide, please. Okay. As has been mentioned, we know there are changes in the brain with people with FND, and certainly we know there's increased activity around the amygdala, which is very much linked in with the limbic emotional system. And clearly over time, scans are able to pick up this higher activity in these areas of the brain. I think you've always got to be careful about this. Is this present at the start, or is it something that develops with the course of the condition? Or is it a combination of both? Do some people have increased activity in the amygdala, therefore they're more susceptible to these conditions? It's very clear that when they have these heightened awareness, particularly amygdala limbic systems, their perception changes. And there's been lots of research we've shown people with angry, happy faces who displayed FND seizures. It's very clear that they respond more to angry faces, and particularly if there's a history of sexual abuse as well, it exacerbates that condition. We know it's also present in children, and they have linked it to attachment theory styles, that children that have better attachment are less likely to be susceptible to this. But if children have poor attachment for whatever reason, they're more likely to display this change in processing. Next slide. Okay, so coming to medical legal side, there are definitely two schools of thoughts. The first one is financial benefits. Illness is injury-related compensation, job forensic situations. Again, there's no illusion that these tests were first designed, particularly in America and Canada. And they were used particularly in the health settings to try and see how general people were. And the logic is that in America, you work on insurance health schemes. Therefore, if you want money for treatments, you've got to fight your corner. And insurance companies were getting increasingly concerned that people were fighting their corner. But again, there weren't strong medical reasons for the treatment. Also, a little bit different in America, for argument's sake, that in the legal framework, that if people are deemed to have an IQ below 70, they can't be given the death penalty. So again, I'm sure if you're on death row, there probably is a slight bias to presume as having a poor IQ with you that you can't be given a death sentence. On the other side is related to the emotional reactions to, as we said, there's a risk that something major happens in your life, like a significant fall or injury, and it causes significant emotional distress, reactions as you're trying to adjust, cope to long-term pain or long-term anxiety symptoms, which again will affect the way people perceive their everyday lives. Next slide. Okay, I think people are aware that neuropsychologists are increasingly called to give evidence in litigations, particularly with respect to compensation claims, to see if people are putting effort into their assessments and to see if they're a fair reflection of their abilities. And obviously, particularly in compensation claims, they're very, very important. And I think two recent cases, which I'll quickly talk, one was a guy who was working in a factory. This is actually a bakery factory, and he was cleaning the machines. And for some reason, the machine came on and he got caught in the machine and obviously had a head injury. So generally did have an event. We were asked to assess to see whether he was putting effort into his tests. Now, the case was slightly more different because he was actually someone from Afghanistan. Fortunately, I took a translator with me. I did the effort test, which we talk more about in a minute, and he failed it, very clearly failed it. And when I challenged his results, he said it was because he didn't understand the interpreter, which obviously backfired on him because he argued that the interpreter wasn't from his village and therefore didn't have his dialect. When this was challenged in court, the interpreter actually was from the next village, and the case unfortunately went horribly wrong for him. Okay, do you want to go to the next one? Okay, so we psychologists, when we do assessments, we need to ensure that people are putting effort in to our tests to try and increase the reliability and validity. And equally, hopefully it gives us areas that we can focus on to treat or guide our treatment in the future. Okay, do you want to go to the next one? Okay, malingering is a very difficult concept for particularly medics to get a hold of. And the reason I think medics are very much geared into the fact that they want to try and treat physical symptoms to make people's quality of life better, which you can understand that logic. Unfortunately, when people exaggerate the symptoms or are creative about the symptoms, they're unlikely to be treated in a physical way. It needs to be physical and psychological to try and get the best response. But medics certainly have a big issue with that philosophy. And certainly I've got a patient at the moment who's been in hospital 27 times over the last 42 days. And it's amazing that despite being on medical records not to admit this lady, she's very successful at getting the medics on her side and getting treatments. And I think the biggest issue, one of the issues, is chronic pain, that recently medics have, despite being told not to, still prescribe opiates because they want to feel they're actually helping the patient. Next slide. Okay, so malignancy says intentional faking, exaggeration of symptoms. As we say in England, we call it lack of effort. It was originally coined at the turn of the century because people were using their symptoms to try and prevent them going into the army, or using it as a way to actually get out of the army when they didn't like being a soldier. Next slide. Okay. Effort testing is widely used in England. The tests now are getting more complex, and we'll start from the basic ones and go to more technical ones. And obviously, as they go on complexity, they are very difficult for people to fake and get away with it. So if you go on to the next slide. The three main tests used in England at the moment, the Tom Green word memory test and mild symptom validity test. If we go on to the next one. Okay, the Tom basically appears a lot harder than it actually is. And in this test, people are asked to learn 50 visual pictures. They're then given a choice of 2 pictures, and they've got to guess or try and guess the picture they've seen before. And they do this over 2 trials. They then have a 30-minute delay, and it's redone if necessary. Now, intuitively, remembering 50 pictures, so people think, you remember 50 pictures, you think, gosh, that's going to be really difficult. In reality, it's not difficult, and you expect people to at least retain 45 out of 50 on the first occasion. Now, logically, I suppose if you look at the way that you think your memory is really impaired, you've got 50 pictures, you probably intuitively think, well, I probably need to get about 25 right. And if I do that, then surely it shows I've got memory problems. Well, the cutoff's 45 out of 50, so there's a big gap there. And as I have had in cases when it goes below 25, i.e. below chance, you know someone unfortunately is definitely exaggerating their symptoms, which obviously can have quite significant implications for the future. Okay, going on to, these are statistics for the Tom. The Tom is pretty reliable in this test, and it has been used on a range of populations, including people with dementia, etc. And we know that even 95% of people non-dementing should pass it first time. And again, it increases in the pass rate when you have the second, undertake the second task. Okay, next group. We know it's very sensitive. And again, people, use this quite routinely, and they use it usually in conjunction with another effort test to try and confirm the findings are accurate. If you go on to the next slide. Right, the latest one, well, not the latest one, the middle one, is Green's word memory test. Now, Green words memory test is very sophisticated, and it has 6 subtests to it. And again, they're using the same material for each subtest, so expect the results to be consistent over time. And if you go on to the next slide, okay, sorry, go to the next one. We've got this is the graph. Now, the important bit of the graph is that the patient should not score anywhere in the grey area. And if they've got any scores like this patient has, in the grey area is a sign suggested that they are strongly malingering. And because you have 6 different subtests doing it in different ways, it's very difficult for people to predict or try and cheat the system. And certainly it's got a very powerful reputation have been very successful in detecting lack of effort over time. The biggest issue with it is the length of time it takes to administer this test, because it can take 30 to 40 minutes. Most psychology assessments usually occur over about 3 to 4 hours in a medical legal sense. So to have a quarter or a third of your time just on an effort test is excessive. And this is where we go on to the next test. So we go into reasons for exaggeration. Obviously, we talked about the medical symptom inventory, which is shorter version of the green word memory test and can be done about 15, 20 minutes. And it's going to be the new measure that I think is going to be more widely used in the future because it's more reasonable to effort test over that time. Now, when someone fails an effort test, it's very important to try and tease out what is going on. And obviously, most people feel that effort tests relate to malingering. Life is never that simple. So again, this is a matrix that came out about 3-4 years ago of potential reasons why someone is malingering. And if someone does fail effort tests, it's very important you try and tease out what is going on. And as you see from the grid, is it cry for help? Is it anger, frustration, self-justification? Is it personality disorder? Is it avoidance of unpleasant activities, secondary games? Is it, a deep-seated psychological need to be sick? And I've certainly seen that in the medical legal field where someone does want to get better because they don't have to take any responsibility for their actions, behaviors, and therefore are more comfortable being at home, being looked after. Okay, go to the next slide. As we said before, you need to tease out and try and work out why they got these unexplained medical conditions. Are they unconscious? Are they intentional? If they're intentional, is it primary consequence, i.e., like I talked about the twin who wanted more attention, or is it more external, linked to compensation? Because people naturally assume that the more disabled you are, hopefully, in medical legal sense, you'll get more compensation or a bigger claim. And claims, certainly do seem to be getting bigger. That was in a conference the other day, and working with a solicitor there who said his largest claim at the moment is 42 million, which is mega monies. So people, unfortunately, see that as an incentive at times. Next slide. Okay, to finish off, I think we all should be aware that involvement in litigation renders plaintiffs susceptible to stresses and influence that may lead to increased impairment, biased reportage, retarded or slow recovery. Underlying personality patterns play a critical role in defining, shaping reactions. And I think we do see in the legal system comments, particularly from medics or active treaters, saying that in some ways the plaintiff's symptoms will improve once the claim has been settled because they don't have these external forces or pressures. I shall hand you over to Michelle now.
Thank you. I'm just going to do a quick time check. Kate, who's helping us in the background.
Got about 20 minutes.
20 minutes left. Okay, perfect. Thank you. We just want to try and make sure that there's time for any questions at the end. So moving on to functional movement disorder. So this is where the primary manifestation is physical symptoms. We know that the onset of these physical symptoms typically is around middle adulthood, with a mean onset of 40 years old. We know that females are more likely to be affected than males. And here at the phenotype frequency are one of the common presentations that we often see from a physical perspective in patients with FND. In some cases, the presentation of the physical symptoms are associated with their personal experience of disability. So I remember having one patient who had previously, she was a teacher in a special school, And she presented very much as though she was had cerebral palsy. She was sort of a spastic diplegia, and unable to mobilize with a lot of spasticity in both of her lower limbs. So she kind of appeared to have picked up some of her understanding of what disability is in her physical symptoms. There are assessments and tests that we can do in order to try and identify if somebody's physical symptoms are from an FND cause. So there's a test called Hoover's sign, which enables us to determine the inconsistency between voluntary movement or their impairment and any automatic movement, which would be preserved in somebody with FND. And many of the patients with FND report sudden onset. So in this study, 54% of patients reported sudden onset within a matter of seconds or minutes. Some present over a course of hours to or a day, and this is not typical of somebody with a neurological condition. There's variability in how they present, with variability with their either persistent and or persistent with variability, or the paroxysmal symptoms that they might present with. And it's important to try and get patients to identify if they've got the associated psychological symptoms, so that they recognize these symptoms if they've got some variability within how they present, in order to be able to manage their symptoms. So I remember having one patient who was she'd had an inpatient stay due to her FND, was discharged home. She was actually a lawyer. She was kind of very high functioning in her job. But she knew that when she had symptoms of dizziness and poor balance and some visual problems, that was a sign that her anxiety was increasing. So she was able to put things in place in order to try and manage it. So understanding those physical symptoms is important. This is the range of some of the common symptoms that we see. So limb weakness is often unilateral, might be one limb or two. That might be with or without sensory symptoms as well. Dystonia is where there's poorly controlled or poorly coordinated movements, and limbs might remain in an abnormal position. So the arm might be flexed, or the ankle might be fixed in a plantar flex position. A tremor, this is where there's sort of rapid oscillating or twitching with a rhythmical movement in one or more body parts. And again, this might increase with stress and anxiety. Seizures is something that we do often see. So they're non-epileptic seizures, and they will appear differently from a normal epileptic seizure. So things to look out for would be their positioning, the presence of incontinence, and also how they come out of the seizure as well, can often be very inconsistent with a normal epileptic seizure. Persistent postural perceptual dizziness, or sometimes called dysautonomia, with a presence of dizziness, visual disturbances, and balance problems. Again, this is quite a difficult one to be able to assess. I've had a patient who had a legal claim. He'd had a history of cardiac problems in childhood. He'd had a history of non-specific symptoms over a long period of time. He developed weakness, which didn't really correlate to how he was functioning. So on assessment, he appeared much weaker than he actually was. Balance problems that he had, and frequent falls without any particular reason. And there's an assessment that we can do called the activity-specific balance confidence scale, which is asking the patient to rate their confidence in being able to do a range of different balance activities. And he was very inconsistent again in how he was actually functioning on a day-to-day basis. So he said he was 50% sure that he could get in and out of his car without any balance problems. Yet when I observed him he was able to do it without any difficulties at all. Patients will often present with a functional gait disorder or have an abnormal gait pattern. That might include leg weakness, balance problems, and some sort of bizarre gait kinematics. Urinary retention is common in women, particularly with functional neurological disorder, but is potentially associated with some of the medication that they might be taking. Cognitive symptoms, whilst they're not motor, often patients will present with difficulties with concentration, memory, and attention, and speech issues as well. So I mentioned the young gentleman who just started university. He developed mutism. He wasn't able to speak at all. It might be dysarthria. So a whole range of different presentations, and I'm sure our speech and language colleagues will be able to give us more details of those. So just finally from me, some of the considerations are some of the comorbidities. As we've heard, a lot of the symptoms can be associated with neurological conditions, and they might have neurological conditions as well. So difficulty in recognising symptoms that might be associated with other conditions, and the importance of recognising any comorbid symptoms. And then thinking about the impact of stress, the association between the biological susceptibility and stress, and just increasing in stress, or their awareness of stress. They might not necessarily be aware that they're stressed at all. And Rob and I have both treated a patient together who didn't feel she was under any stress at all. She presented with mobility problems and seizures, non-epileptic seizures, but she said, I'm fine, everything's fine. And yet when we started to talk to her, she expressed that she had her husband was alcoholic. She had twin boys, one of whom was born with amputation, loss of both limbs. The other one was autistic, and then she had a younger child, a girl who was 2. So she was dealing with all these stresses constantly, but she didn't really feel that she was stressed. So just considering the impact of stress and the presence of FND. So I'm going to hand back now to Rob for his last few slides. Over to you, Rob.
This lady who was referred to our service, who had supposedly a suspected stroke, it was very clear that her presentation wasn't quite right. She was threatening litigation because she had reported having a series of migraines before the stroke, and therefore felt the medics hadn't taken her symptoms seriously. As I was saying, that her speech was very dysphasic, but she had normal writing ability and comprehension, which is unusual. As you said, she had a left-sided hemiplegia, left-sided weakness, strong weakness, but on the CT and MRI scans, nothing abnormal was found. The consultant at the hospital felt she had a stroke. She also had a history of epilepsy and had been on steroids, had a range of other medical conditions. The only one of real significant note was that she had a parotid tumor excised 20 years ago and radiotherapy, followed by osteoporosis of the jaw requiring surgery, particularly to an inner ear area. It was thought that she had a psychosomatic overlay to her speech problems, and she benefited from input. I'll go on to the next slide. When we looked and got her medical records, it was quite incredible the amount of admissions she had for all sorts of different conditions. And, she'd taken up a lot of health service resources. Interesting, this last one, she was talking about possibly litigating for poor treatment. But but a history obviously clearly indicated significant FND related symptoms. It is also very interesting that when we did take a full history, there were unfortunately big emotional issues, that she hadn't been getting on well with her husband for many years. She also had 3 children who she was struggling with in coping, managing, looking after them. She's also very resentful that she always wanted to have her own career, and this had not been possible. So if we go on to the next slide, when we looked at it, she'd had 2.36 known hospital admissions, and this is on top of outpatient treatments, GP treatments, over the past 20 years, which is incredibly high level. I'm pleased to say that following the treatment, a 4-year follow-up, only one hospital, she'd only had one hospital admission, and that had just been for 4 days. So there's this significant difference in her presentations. Okay, we'll go to the next slide. Ed, I think you're on. Ed, are you there?
Indeed, I am. Thank you, Rob. That was really extremely helpful. So I'm just going to wrap up for the last few minutes, talking a little bit about the treatment approaches, just in outline. And clearly, the key is not to assume a one-size-fits-all. And we find this in the management of all kinds of complex disorders, which require rehabilitation. And the rehabilitation paradigm here is terribly important with functional neurological disorder. Oftentimes we find in especially severe cases that hospital placement is required, which of course in the context of the litigation environment brings with it significant cost. But then of course there is very significant cost to not treating the condition of FND. A multidisciplinary approach is best, and we've already heard today from a consultant clinical neuropsychologist and a neurological physiotherapist who clearly have extraordinary experience of dealing with these problems. Other team members are, of course, important. I would hold up a flag for the rehabilitation physician, naturally, but neuropsychiatrists clearly do play a role here. Treatment should be related to goals, clear goals. This is, of course, good rehabilitation practice, and task related, so functional approach. And the aim should be to reduce the threat value of symptoms and help patients to become more self-managing. So a couple of points about treatment approach in the communication of the diagnosis. And again, we said earlier on, this is a positive diagnosis. This is not a sort of, well, you haven't got all these things, therefore you've got FND and a big sigh. One has to acknowledge the problem with the patient and explain what it is that you have FND rather than what it is not. It's not MS and it's not a stroke and it's not just depression, because that doesn't help patients. They need to have a clear understanding of what we think the paradigm is and how we're going to work with it. Positive aspects of the diagnosis can be shared with patients, and we need to assess their response to the communication of the diagnosis. So we need not to assume that they understand the diagnosis. It's complex, and oftentimes a lot of energy is required in that dialogue with patients to help them understand, and often that can take more than one session, and with more than one professional. It should be a consistent approach, of course. We need to discuss the possible triggers and risk factors for how this arose in their life, as we've heard particularly Michelle talking about, and also the risk factors for perpetuation. So what is it that's keeping this going? Of course, we need to talk about treatment options and we manage the physical symptom comorbidities. Supportive literature in modern healthcare, of course, is very important. Everybody has access to the internet. Sometimes that's not helpful, but it's very helpful if they have a guided approach. Physical treatment, not to focus on the movement or its constituent parts, but FND patients can benefit from physio techniques which take attention away from the movement. So sometimes using approaches that may seem a bit paradoxical, they need to focus on function and tasks. This is, of course, again, the rehabilitation paradigm. Avoid, if possible, the use of equipment, splints, walking aids, and so forth. That tends to reaffirm the problem. And focus on day-to-day functional activities rather than impairments. Treatment of psychological comorbidities is important, so anxiety, panic disorder, depression. And they, as I say, comorbidities, these are problems, conditions that exist alongside the FND. They may, of course, be directly related to it, but they may exist in any case in isolation. So they need to be treated. I'm not going to say anything about dissociative seizures there. Medication, in practice, many patients with FND come to clinic over-medicated, and we see this very commonly in all patients, actually, as they age particularly, and certainly this is a fundamental problem in the care of the elderly, and indeed they present with a lot of complex symptoms and signs as a result of the side effects of medication. But anyway, these FND patients often benefit from a targeted reduction of medications, particularly these three groups. So the opiates, the gabapentinoids, and the benzodiazepines. Opiates are particularly a difficult drug for patients, and there's a substantial campaign worldwide to reduce the use medically of opiates. So the prognosis. Long-term follow-up studies indicate that 40%, 4 out of 10 people will remain with similar or worse symptoms. Most patients will remain with some symptoms which are disabling. So it's terribly important that we, first of all, engage the rehabilitation paradigm, so to try and improve function where possible, but that eventually, once patients have plateaued, that we engage a disability management paradigm, because if you have got ongoing symptoms and ongoing effects of that, then you need strategies for maintaining as good a quality of life and as good a participation in life as is possible. The longer between symptom onset and treatment, the worse the long-term prognosis. That seems self-evident in many ways, because problems become entrenched. And patients with severe pain and fatigue generally fare worse than those with less severe symptoms. I like this comment here, a definition of pain. I think it's apposite in terms of functional neurological disorder relating to other symptoms, so fatigue, for example. Pain is whatever the experiencing person says it is, existing whenever and wherever the person says it does. It's not for us as external practitioners or indeed lawyers or insurers to second guess patients' interpretation of their symptoms. It's for us to take that at face value and help them potentially to reinterpret in a more functional paradigm. It won't come as any surprise that patients with severe enduring mental illness, especially personality disorder, have a poorer long-term outcome. So finally, the challenges within the litigation context. So personal injury litigation involving FND can be challenging in several ways. We know that in our practice, multiple reports and assessments are required. And these, by their nature, may generate anxiety, conflict, and misunderstanding within patients, within our clients. And indeed, we see this, whether patients have got FND or not. FND can be difficult to diagnose, as we've heard, and distinguish from other conditions. And that makes a real headache for those who are trying to attribute causality to patients' symptoms and the disability arising. It can be difficult to determine if a claimant had FND before an incident that caused an injury. And that's where very good history taking comes in, very good review of records is important. FND can cause debilitating long-term effects alongside the effects of other conditions, and treatment can be expensive. As I've said earlier on, oftentimes treatment for FND requires inpatient admission, and that may be alongside the other pathologies that have arisen in an accident or in a negligence. And finally, insurers, particularly, and defendant solicitors, may be sceptical of FND cases, particularly because of the lack of an organic explanation for the symptoms and the potential for high claim values. Now, just remember what I said earlier on. That's why I put up the references to the literature. There is an emerging science to try and understand what it is pathophysiologically that is driving FND. So, finally, all of these factors point to the need for truly expert assessment by clinicians experienced in the diagnosis and management of FND, whether the possibility that it is a contributing factor to a personal injury claim. I think that's my takeaway message for you, and therefore the engagement of professionals like Rob and like Michelle and some of our neuropsychiatry colleagues, some of the rehabilitation physicians, is terribly important to be able to get to the nub of the problem that a patient is presenting with who has FND alone and or in addition to other conditions. Okay, I think that is my final slide. Yes, so I'm happy to take questions. I do know that we're just 1 minute overdue now, over time budget. We don't have any, extraordinarily, we don't have any questions, but I'll just make a few summary comments, if I may.
Ed, we've had some questions, but for some reason they've disappeared, because I'm intrigued by one question, and I think it's a really good question, is that obviously made the comment that some of these symptoms improve once litigation has finalized. What is the evidence for that? It's a really good question because a lot of patients aren't followed through after the settlement of litigation, but there are several factors that I think are relevant to that. One is, I think we've all worked with cases where as part of the settlement, they've had quite a lot of costings for therapeutic medical input. And miraculously, once the claim's been settled, the plaintiffs then decide they're not going to follow through with the treatment, which obviously gives them a big financial boost to do other things with. And I've worked with patients that have cancelled their therapy team and gone off traveling, which, yeah, in some ways I admire. Other times I have worked with a couple of cases where they have had quite good settlements with respect to therapy input, and we worked with them for 1 to 2 years, and then they decided that they're happy with the level they've achieved, and again have sacked the therapy team. Now, either that means the therapy team have done a bloody good job, or I suppose the other way, that they think they're not helping. But I do think that once, and it is the way our legal system works, that once a claim is settled, that's it. You can't go back and re-challenge it. So, it's a good question. The evidence is not strong because we don't, by and large, follow people through after they've had settlement. But, from my experience, as I say, people have got rid of the therapy team afterwards and prefer to use that money for other reasons or other ways. I hope
yes, I think that's
that question.
Too, Rob.
Sorry?
I agree with that. I agree with that. And it's extraordinary, but I can't see the questions.
Okay, I'll come to it. So we've had one question from Emma who said, would someone with FND be expected to pass the effort test?
The answer is, as we go through, that you've got unconscious and conscious. I always think, and more views now strongly, that when I get a person with FND, I'd automatically do an effort test. I do think if it is more conscious, definitely you tend to find that they fail it because they're trying to prove that their condition is serious. And routinely I do that now. And certainly, I think probably 90% plus tend to fail the effort test.
Right, I can see the questions now, which have arisen. So let me just, let me pick 1 or 2 out. How long after trauma would you expect to see FND symptoms? Sometimes we see the onset of symptoms months after trauma, and there's a query as to whether it is related or something that would have arisen anyway. Rob, do you want to have a go at that?
Yeah, again, it's probably mixed answer, and I'm sure Michelle will chip in. Quite a lot of these cases, you usually have what I call an index offence. Something happens that's highly emotional, when people are stressed, and therefore it triggers a higher emotional reaction, and you're more likely to see FND related symptoms. There are clearly, if you look at the research, that there are some cultural issues, and certainly Puerto Ricans, I don't know why, have the highest incidence of FND in their culture. So obviously there must be some cultural bias as well. But I do think people usually in these situations have susceptibility, whether it's family links, genes, or whether it's linked to mental health issues. And we mentioned about depression being very common, that there are factors, trigger factors that make you more susceptible to these situations. Michelle, do you want to add on? Or
yes, just to say that the going through the litigation process can be very stressful in itself, and I think maybe as the case progresses, I think if individuals are being assessed repeatedly, questioned repeatedly, that can often add to the anxiety and stress around the whole situation. So whilst I think we know that there are the kind of the predisposing factors, I certainly think the litigation process can add a lot of layers of stress at a number of different levels, which can then cause some of the presentations of FND to develop later on through the process.
We can see that as a perpetuating factor. So if you think about the predisposing, precipitating, and perpetuating factors for these conditions, we've got quite a few more little questions here. Can I just whip through some of them? So one question is, could someone with FND report chronic pain? Yes, I think is the short answer.
Yes, very common, very common.
That's an easy one. Can you recommend any MDT facilities to treat FND? Probably that isn't something we want to do now, but I think if the questioner could write to us, we would certainly do that. There are some, but not many. So there's a question here, where surveillance is inconsistent with movement disorder and balance complaints, what effort tests can assist, if any? Rob?
My feeling nowadays, certainly the green word memory test and the medical symptom validity tests are the two that I consider the most reliable and effective. And certainly I'm using the medical symptom validity routinely now because I do think it is the most reliable measure out there. And I think if you're going into litigation, you want to have the best of the market.
From a physical perspective, if the question was around sort of balance and mobility, then doing the whole range of assessments that we can do from a balance perspective, looking at their vestibular system, their visual system, their motor system, and using a whole range of different assessments that are out there in order to be able to determine the level of somebody's functional ability and comparing that with maybe how they might be presenting at other times. So that inconsistency from a physical perspective is what I would be looking for.
Here's a question directly. Sorry, can I just ask this one? It says, Mr. Poppleton, is there a difference between FND brackets cognitive and malignant neurocognitive dysfunction brackets MND? Wouldn't MND be intentional and FND be unconscious?
I think these are complex decisions to be made with respect to those diagnoses. As I said in the talk, I do think FND is more on a continuum now. That I think to try and think it in just black and white terms is not helpful, because I do think at times, particularly medical legal, the professionals you see can have an adverse effect on the symptoms and the way you present symptoms. But I do think both can be conscious at times. It depends on the situation and depends what people are having to manage.
So we're now 10 minutes over our allotted time. There are a few more questions still coming in. They're broadly in the same vein as those that have been answered already. I think we will wrap up. So if I can just say, this has attracted 202 attendees to this webinar, which is an extraordinary number. And I think it indicates just how important and how uppermost in the minds of many of us involved in the medical legal process FND truly is now. So really want to thank Rob. Thank you for your contribution. Michelle, thank you for your contribution. And thank you all, for 202 of you who are now down to 135, so people are slipping off the lunch naturally, for coming along. And if you would like to know more about FND, or indeed if you have a case where FND is postulated or has been recognised, please do contact us at NRC Medical Experts, and we will be happy to discuss informally, engage formally, either with our clinical services to help with treatment, or the medical legal services to help advancement of a claim. So I think that having been said, thank you all, and I think we'll conclude there. If anybody would like to write in with a further detailed question, more than happy to answer those or attempt to. But I think it's been a really excellent webinar. So thank you very much and good afternoon.